Thank you. Good morning. Thanks for coming. I hope this is not too boring. So I'm going to be talking about CHWs, but in reality, what I want to convey is try to address the issue of integrating community work into a health system strengthening approach. And as you all know, CHWs are part of a community health system. But if we analyze, if we see the WHO's building blocks components, I personally don't see the community in there. So I think it's something that we need to address, and as soon as possible. The other point that I'm going to be including is we're working in a conflict type of environment. You know, South Sudan. It's a post-conflict, fragile state where health systems are extremely weak, and health systems are, it's an urgency to address. So how do we, as a faith-based organizations, as an international non-governmental organizations, how do we address those issues? How do we complement what governments are doing in trying to address health system strengthening gaps? So I'm going to be trying to address that. So I'm going to be talking about a little bit about a background about South Sudan, what's the status of South Sudan, the context in which we implemented this project, which was a centrally funded USAID Child Survival Project. I'm going to be talking about the methodology that we used in implementing the final evaluation, because all these results are based on a final evaluation. And what were the major findings that we found? Also, we did a live saved analysis, the list, to measure the impact on mortality that we had in implementing these interventions. Also, we're going to address the limitations that we have in implementing these type of programs in post-conflict fragile states, the conclusions and some recommendations. So World Vision implemented the community-based maternal and child health transformation project from September 2010 to September 2014. As you all know, South Sudan is a fragile state. It's post-conflict, and some would argue is still there's still conflict in South Sudan. So we work in this state, Warrap state, in two counties, Gogrial East and Gogrial West. The overall of the project was to increase the utilization by the populations of these counties, increase the use of high intervention, evidence-based and high impact interventions to improve, of course, the health. The target population were children under 5 and pregnant women. The population estimated in these two counties is almost 105,000 people. The direct beneficiaries were almost 60,000 children and women. The cost, it was $2 million overall over 4 years period. And the main activities were, we used ICCM, Integrated Community Case Management, with a little modification. We included a newborn component into the community case management, but that component was part of operational research, which was implemented, immersed in the overall project, but did not include the whole project. So we delivered the services through home visits by community health workers. The community health workers were supported by groups of community mothers leader groups. And also we implemented within the CCM a supportive supervision model that we wanted to test as well. The other part of the intervention was that the project supported financially 5 selected members of the communities to go and receive a 3-year training on midwifery skills. That was outside the project. They went to a university, but the project supported financially as part of the intervention. So in 2005, the government of Southern Sudan, later known as South Sudan, operationalized 3 levels of healthcare. The primary healthcare unit, which was the most peripheral delivery point of delivery in the system, the primary healthcare center, and the referral hospital. However, the health system in South Sudan, as you all know, remains severely constrained by chronic and severe shortages of human resources. Currently in South Sudan, I believe there are only 126 trained physicians and 211 trained midwives for a population of almost 8 million, 2.6 million people. So it's way below the recommendations from WHO, which I'm pretty sure you know it's 2.3 per 1,000 people. So nearly 85% of the health services in South Sudan are provided by either international NGOs or faith-based organizations, 85%. And as you all know, the health indicators in South Sudan are extremely, extremely bad. It has, some argue, the highest maternal mortality rate in the whole world, with 2,056 deaths per 100,000 live births. So maternal mortality ratio is extremely high. And an infant mortality rate of 68 per 1,000. So South Sudan has one of the worst health indicators in the whole planet. And that's not strange given the situation of the health system in that country. So we did an evaluation. It was a mixed methodology. It was quantitative and qualitative. Within the quantitative, we used a quasi-experimental design before and after. We used a sampling technique, the 2-stage randomized selection with 2-stage 30-cluster sampling. We didn't use LQAS. And the target population was, of course, mothers and children aged 0 to 23. We did as well a qualitative methodology, qualitative research, mostly doing focus groups and key informants. This was an external evaluation done by Dr. Frank Anderson from the University of Michigan. And we actively participated in this. In fact, the quantitative data, it was collected by World Vision US in collaboration with World Vision South Sudan. The qualitative information was directly collected by Dr. Anderson. As you know, in any evaluation, you need to have some questions. Evaluation per se, it's a type of research. And in order to do good research, we need to have a question, at least. So we did have 3 questions. And we wanted to know to what extent what we were implementing was done according to our detailed implementation plan. We wanted to know what key strategies and factors did have an impact and which ones did not work. We wanted to know that. That's a very important information, sometimes even more important than the positive one. And we wanted to know also, do we have any sustainability? What kind of sustainability do we have in the interventions that we're implementing? So these were the three main questions that we wanted to answer. So regarding the first question, we noted increases, and statistically significant increases, substantial increases in maternal and child type of interventions. And we did notice some changes also at the health facility in terms of increasing the infection control type of approaches at the most peripheral health unit. In the maternal side, these were the changes that we noticed, and all of these are statistically significant. We noticed increases in the percentage of women who had 4 antenatal care visits from 12 to 29%. Also, we noticed increases in the tetanus vaccine coverage among these pregnant women, and also changes in the in the management of third stage of labor. And that was based, we didn't really do an observation type of activity. It was based on questions, on 3 questions related to active management of the third stage of labor. And also we noticed that women were using the bed nets. In terms of the children, we noticed that because this was a CCM program, that was the strength of this program, we noticed that there was increases in in the coverage of all 3 diseases. As you all know, CCM, when you say integrated CCM, it includes the provision of services for diarrhea, pneumonia, and malaria. So you can have CCM programs which are vertical, which include only 1 disease, but if you said integrated CCM, includes the 3 diseases. So we noticed increased in all 3 diseases, in the coverage of all 3 diseases. And this was really important for us because based on this, we were able to apply the list analysis in order to measure the impact on mortality that we were having through the application of this intervention. So you see that ARI, acute respiratory infection, went up, malaria went up, the treatment of malaria went up as well, and the treatment of diarrhea went up as well, very significantly. And take into account that we're talking about a post-conflict, or I wouldn't say post-conflict South Sudan. I think South Sudan is still a conflictive area. And several times when we were implementing these interventions, we were forced to stop the program because of violence. So take into account that factor. These are most of, I know that you're going to be able to see it, but just to show you that these are all the indicators that we collected. And we have, if you need us to go more in detail, we can facilitate those. In terms of what were the strategies that worked, so as I was saying, this project was implemented during a time of great transition in South Sudan, and the context issues of civil war, intense relief efforts, remote location, coupled with weak infrastructure and very small supply of locally available professionals, staff, as well as high cost, all led to a high staff turnover. We had 4 program managers in 4 years, and that really hits when you're implementing this type of projects. And the issue was that the environment in which these program managers were working, it was really hard. So you have to take that into account when you're implementing these type of interventions, that you should expect high turnover of project staff. We did have limited ability to supervise because of the environment, the violence and the insecurity. And we did have limitations in providing refreshing trainings as we would have liked, or if it was included in the detailed implementation plan. We found limited impact on some of the indicators. Most of the indicators that really didn't increase were related to a central supply logistics. For example, immunizations. We really had a problem with the supply of the biologicals from the central to the regional to the local health system. So we were, and given the violent environment, the conflict, immunization really took a hit. And during the 4 years, even went down the coverage of immunizations. So, and that's testify the type of weakness that we faced in this type of environments. So we did contribute, the program really, one of the strategies to contribute within the health system was to address health resources, which is one of the components of the health system strengthening approach, WHO's approach, service delivery. We try also to address supply. And the way we were going, the way we work in the health workforce, we worked in the recruitment and selection, plus the task shifting that we did using the community-based approach. And this was specifically to mitigate the health resource acute shortage. And also we did a pre-service, we addressed the pre-service education with the support that the project provided to these midwives, which at the end of the project, they came back to the area to provide services. In terms of the performance of the health workforce, we used two strategies: in-service training and performance appraisal. All of the performance of health workforce was focused on the community health workers. We didn't really implement anything of this at the health facility. I have only 5 minutes. So the major findings on which elements of the project are likely to be sustained, well, we really think through the qualitative information that we collected, we really think that the maternal and child health agenda was strengthened within the local area, and and one of the results of this reshifting the agenda in this area is that the regional hospital was, the Ministry of Health really focused on strengthening the emergency capacity to address newborn and obstetric services. So there was a link between the community work that we were doing and identifying women who needed obstetric services in emergency situation, as well as newborn. Now there was an effort from the Ministry of Health to have a delivery point, which we did not have at the beginning of the project. So that's one of the proofs that we have that it provides some sustainability to what we were doing. This is the list analysis that we did. I'm sure you are all familiar with the Life Saved tool. And so we were able to measure that according to this analysis, the project achieved an aggregated 8.24% reduction in under 5 mortality rate in a period of 3 years of intervention coverage. 2.95% from 2011 to 2012, 3.18% from 2012 to 2013, and 2.11 from 2013 to 2014. The UN Interagency Group for Child Mortality Estimation estimates an average reduction rate of 2.8% for the period between 1990 to 2000, and 2.8% from 2000 to 2011. So by using community structures, by using with a cost of $8.33 per year per beneficiary, we were able to achieve an impact on under 5 mortality which is equal or above what the UN estimates for the country. So for us, this is a clear evidence that by using community approaches and in close coordination with the Ministry of Health, but in those cases in which the Ministry of Health is really not able to cover these people or their people, so this type of approaches, it's a real alternative. It might not be the cheapest alternative, but it's a real alternative, and we believe it's a cost-efficient alternative to really have impact on mortality. These are some of the limitations that we found when we were implementing this project. Poverty all over. Of course, civil instability, extremely limited infrastructure, limited skills capacity. As I said, I mean, way below what the WHO estimates the workforce needed to coverage with the basic interventions. Rural areas with poor roads, seasonal flooding, no bridges. We had only one vehicle. That was another limitation for us. So in this type of setting, transportation, it's going to be an issue. So we need to factor that into the project, into the budget. The frequent staff and management turnover really hits a project. The inconsistency of supply drugs. So in this type of setting, post-conflict or conflict, we shouldn't be expecting to get the drugs from the ministry. We're going to have to get the drugs ourselves. And also unexpected costs. These are expensive projects. So in conclusion, our project successfully initiated community-based healthcare services through home health providers, who are the CHWs in South Sudan, and other community organizations. We successfully worked with the state and county MOH to increase quality and access of services. And some aspects of the project will continue through other World Vision South Sudan projects as a result of this. We already are engaged in a project in the Kwajok Hospital, in which we, World Vision South Sudan, in collaboration with World Vision US, is strengthening the capacity of that hospital to provide obstetric and newborn emergencies. And that's linked to the community structures that are already set in place in that area. The recommendations. We need to do more OR, operational research. We need to focus on supply management. We need to focus on supervision. As a PVO, as an NGO, as a faith-based organizations, we need to be sure that if we're going to be implementing community case management and we're going to be delivering drugs to children, we need to have supervision all over. We need to emphasize supervision. Supervision is one of our weakest links in the field. and staffing and capacity. You know, staff is the one, staff, human resources are the one who are delivering these services. We need to be sure that they receive what they need. And if we're going to be implementing community case management, it's training, it's supervision, and it's drugs. You don't have any impact if you have a physician in the field with no equipment, with no drugs to deliver the services. So supply management is another thing that we need to focus in this type of projects. Thank you.
I'm going to be talking about a similar project in some ways, the Maasai Community Health Worker Project, improving the health of their people. And I'm going to start with a little bit of background about the project itself. I'm going to talk a little bit about the Maasai population, and most of my talk is going to center around the project itself, how it was set up. We're a year into the project. It's a 3-year project, and so I don't have a lot of data and information. This is mostly going to center around the project itself. So the project CHAP is the Community Hospital Alliance Program, and it's a program to provide health education and health services to 21 remote Maasai villages in northeastern Tanzania, and to connect them to health services. So because they're very remotely located, they don't really access health services, not surprisingly, because they're so far away. And so that's part of the project here, is to really make that referral connection for them, but in addition to provide them with health education and health services within their communities as well. So the project started with Global Health Administration Partners, which is a program out of Minnesota. And we're part of Global Health Ministries, which has been around for about 30 years, and started by shipping supplies and equipment to mission hospitals overseas. And what GAP, or Global Health Administration Partners, does is we provide services to help those mission hospitals to support their leadership and management functions. And we partnered with Empower Tanzania, which is an organization that works in Same, Tanzania, and has been working there for a number of years, mostly supporting more agriculture types of projects, and they were getting into health projects. And so they partnered with us because we specialize more in health. And this was a great partnership. You can see on your right-hand side here, Dr. Jeff Carruthers and Phil Latessa, who are 2 of the people that started Empower Tanzania. And they reached out to us because of our capacity to work in the area of health. And what they wanted to do, they saw a need with the Maasai population to have community health workers, and so they reached out to us because of our capacity around health. They've been working in this area, and they have staff on the ground. So on your left-hand side, you see Eli Bariki Kasimbo, who is the head of their development arm in their Tanzanian office, Pastor Mpinda, who is the head of their palliative care program there, and then Dr. Alfred Set and Dr. Chambua, who are the 2 supervisors for our community health worker program. So part of their strength that they brought to the program was having people on the ground in Tanzania who could oversee the program there. So this map is by no means to scale, but what we did was we tried to map out what was going on in the area in terms of where the Maasai communities were. One of the things that we quickly realized was there's no data and there's no information on these communities. We really had no idea where they were. We had no idea how many people were in these communities. And it was a hard place for us to start from. So we were told there are anywhere from maybe 10 to 12,000 people to 50,000 people in the communities. And so we needed some sort of starting point. And so we had an MPH student who happened to be out there for a couple of months start driving around and sort of figuring out where these communities were. And so this is a map that sort of gave us at least an idea of where they were in proximity to some of the villages that we knew about. And so in the area, there are two tribes. There's the Pare tribe, who actually has fixed community locations, and then there are the Maasai. And so what you see on the map are typical villages. These are the Pare tribe, and then located somewhere around them are the Maasai. And what you see in the larger black squares are where we know there are health centers. So it helped us at least to get a fix on sort of what we were entering into in terms of where they were located health facilities and sort of where the Maasai were in sort of location to those health facilities. So the Maasai communities, and a little bit about the Maasai for those of you who aren't quite as familiar with them, they're a tribe that's located in the Tanzanian, Kenyan area, kind of across the border there. I call them semi-nomadic. They used to be a completely nomadic tribe, but they live very remotely from others. And so that's why I say that when there's a village, it's a village of the Pare people, and then the Maasai live somewhere out from there. There aren't any roads to get to them, so that's why healthcare is an issue for them, and they walk everywhere. So here's one of our Jeeps trying to get to one of the villages. We got stuck, not an uncommon sight. They live in bomas, which is a family group. It's a compound. These are their houses. And multiple bomas make up a village. And so you may have 2 houses, you may have 5 houses, you may have 10 houses in a family compound. And then you have multiple of these family compounds that make up a village. There may be, 2 family compounds or 2 bomas, and there may be 10. So it really varies in size. They speak Ma, which is an oral language. It's not a written language. And very few of the Maasai are literate in Swahili, which is the national language. So coming in and working with them and developing community health workers was a significant challenge in terms of thinking about, how are we going to train them? And how are we going to evaluate the program and collect data? There are extremely low educational levels. We know that there are a few births in healthcare facilities. We believe that there's high infant and maternal mortality, but there are no statistics. And we were told that high blood pressure was a problem, but there's no statistics. So the government has no census data on them because they're semi-nomadic, so nobody really knows how many people there are, and we have no health statistics. So there's really no information for us to base any of this on. We surmised again that there's a lack of knowledge about clean water, sanitation, and disease transmission. Now, I've done work with other Maasai tribes in the past, located in other areas, so I did have some information about what their knowledge base is and some information about, basic understanding of clean water, sanitation, and disease transmission from other Maasai tribes, but it doesn't necessarily mean the same thing in different places because other tribes may be located closer to a city, they may have more interaction with other people, and so it just really depends a lot on who they're connected to, who's been out to see them, how remotely located they are, and so it really varies a lot from one group to another. So our goal was to improve the health of the community. We weren't sure exactly what that meant because we really had no baseline yet. But that was the goal, was to improve the health. And you can see here, we don't really know a lot about the ages of the people, but you can see here it varies a lot. Kind of up in the right-hand corner, we have an older woman. We're guessing she's probably somewhere in her 80s, not really sure. And in the bottom right-hand corner, an older gentleman. This is really funny because I'm from Minnesota, home of the Minnesota Vikings, and I walk into this Maasai village, and here's this guy who has on a Minnesota Vikings stocking cap. So the first thing that we did was we had meetings with all the village elders, the chiefs, and the ward councillors, which are the government people in the area. So the way the government breaks down, it breaks down into wards, and that's what level of government official we needed to meet with to get approval. So we already had approval at the higher level of government. That had already been done through our connections with Empower Tanzania. And the expectation then from the higher level of government officials was that we would come in then and meet with the ward councillors, meet with that level, meet with the village elders and the chiefs. And so on the left-hand side here is one of the ward councillors. In the middle are the village chiefs. And then on the right-hand side are the village elders with Pastor Mpinda. And then we actually went to each of the village meetings where they selected the community health workers. And we had criteria for the community health workers. They were going to be all women, because for the most part it's women and children that we were addressing the health issues with. And we knew that women needed to teach women. And so when we were looking at health education, we knew that that was one of the things that we needed to accomplish. And of course, who takes care of the family? It's the women. Who's going to be purifying the water? It's the women. Who's going to be doing the cooking? It's the women. So that was our focus. The other things that we knew were that when the women get married, they leave and they move to the husband's boma. So we needed to have a married woman because we wanted them to stay within their community. They also needed to be literate in Swahili because that's what we were going to be teaching them in during the training. And so that was a challenge because not many of the women go to school. So we knew that we were going to probably have younger women and that they were going to be educated women, and that was going to be more difficult for us to find. So you can see here on the right, this is one of the villages meeting, and all the villagers who could come came. They met, they talked about the young women who met the criteria, who they were, whether or not they would be able to fulfill the role, if they had young children, what other commitments they might have in taking care of the elders in their family, and then whether or not they could get their husband's permission to be a community health worker. And then all the young women who met those criteria, the village voted on them and decided who would be the community health worker. And so it was a really interesting process to follow, and it was great to be a part of that. And then they celebrated by having a feast, and so they would roast a goat, and we'd all eat. Then we interviewed each of the community health workers, and it was really wonderful. It was a great way to learn more about them, where they were from, the ages of their children, their educational level, what they thought about being a community health worker, their aspirations. Did they want to do more education? Just a little bit more about them. So it was really fun. And you can just see some of the community health workers here and our interpreters. So then we brought them together for the training. And for some of the women, most of them actually, this was the first time outside of their village. So they came together in a hostel. We had them stay together for 15 days. And during that 15 days, they were taught a number of different things. So they were taught about clean water, about sanitation, about building latrines. Although the women don't build the latrines, the men do, but we taught them the basics of building a latrine. They were taught about preventing malaria, about using bed nets. We gave them stethoscopes and blood pressure cuffs, and they were taught about taking blood pressures and what's a high blood pressure and a low blood pressure, and when to refer somebody to the health center. We taught them the danger signs of pregnancy and high-risk pregnancy and when to refer somebody to a health center. And so the focus was on simple things that they could do in the community, first aid. They were taught about how to dress a wound, a cut, a burn. So things that they could do, tangible things, but a lot about how to refer and when to refer things to a health center. So trying again to make that connection of what was serious and what they needed to refer on, And then the real focus, again, was health education. What can you do to educate the people in the community, and what do you need to do for health prevention? And so a big focus on health education and health prevention. And of course, because these are women with young children, they had all their infants and toddlers. Everyone that was breastfeeding brought their kids with them. So we had 30 women and probably 17 children under the age of 2 while we were doing the training. So it was very interesting to have all of these people together. There were a few husbands who came during the very beginning of the training just to be sure that we weren't like taking their wives away anywhere or anything. They were still had a little bit of concern about who are we and what were we doing. And, you know, so we spent some time talking with them about the fact that we were educating them about, you know, health issues. And they were reassured that their wives were learning and being educated. They were going to come back to their village and help to take care of the people in their village. And so they went back home. So there was still that little piece that the men really needed to be reassured that, you know, their wives were going to be okay and that we weren't doing something that was untoward with the women in their village. Because it is, their wives, you know, don't ever leave their villages. So this was something that was really different for them. And here's just some more pictures of them during their training. So, and on the right-hand side, you can see the 2 nurses who actually conducted the training. Nurse Nevo is a specialist in reproductive health care, and Nurse Judith is a medical surgical nurse, both Tanzanian. And so they conducted the training, and the 2 nurses and myself designed the curriculum. We took the traditional birth attendant curriculum that's designed by the Ministry of Health, and the home-based care curriculum, also designed by the Ministry of Health of Tanzania. And we took bits and pieces from both of those, and then we added a few things ourselves and put that together, and that's how we designed the curriculum. Data collection. This could be a whole talk in and of itself. Data collection was a huge challenge. A year into the project now, we have data from our first round of data collection, and it was a huge challenge. We didn't get very good data for a lot of different reasons that I won't go into, but because of the challenge of language, we used pictures because not everybody could read well in Swahili, and so it just didn't go particularly well. We're hoping with our next round of data collection that it goes better. We did also do qualitative data collection, so we do have a lot of anecdotal data that so far the community health workers have made a difference in being able to refer mostly pregnant women to the health centers. We just finished refresher training, which went extremely well. And for lack of time, I'll just flip through this quickly. But basically, this is what the community health workers do. They get up, take care of their kids. Somebody else in the boma will take care of them for the rest of the day. They walk to another boma. They'll go over some health education with them, walk to another one, do some blood pressures, walk back home, take care of the goats, make some dinner, and that ends their day. So lots of challenges, and referral and transportation, as Alfonso talked about, huge challenges because the rainy season you can't get anywhere, and so it makes it really hard. Transportation is a big issue for them. So lots of opportunities and strengths as we move forward, and I will end there because I'm out of time. So, thank you.
Hello, I will introduce myself. My name is Fouzia from Pakistan. I did my post-graduation in general surgery from Pakistan, and then I did postgraduate in human resource management from Edinburgh, Queen Margaret University. Now I am working in a rural desert area of Pakistan. We are 300 kilometers away from metropolitan city Karachi and 80 kilometers away from the Rajasthan-Indian border. 47% of the people living below the poverty line. And the infant mortality rate and maternal mortality rate is very high. 80% women, those they are pregnant, are anemic. So they are giving birth to premature babies. And the literacy rate for men is 36% and women is 11%. Now I would like to share a video with you people that how we are working in that rural desert area of Pakistan.
Kunri Christian Hospital is located in Third Desert in southern region of Sindh province. It is 300 kilometers away from metropolitan city Karachi. The total area is 19,389 square kilometers. The livelihood source is rain-fed cultivation and livestock rearing. It is the only fertile desert in the world. The area is a historical embodiment of Jainism and Hindu mythologies of 1,000 years and has beyond 20 archaeological sites of Jain temple and pilgrimage. Water shortage is the key cause of miseries and diseases in the villages. Due to lack of safe drinking water, a majority of villagers are kidney patients. Similarly, the livestock is also dying due to lack of proper drinking water. Unfortunately, the groundwater in majority of the areas in Thar is saline, which is unfit for human consumption. This is a self-evident fact that 47% of people of this area lives under the poverty line. The idea to provide basic health facilities to Third Desert people was originally conceived by His Excellency Right Reverend Chandu Roy. He appealed to the Girl Guide Britain Foundation for financial assistance for mobile hospital activities in 1960. The idea was further supported by Right Reverend Bonaventure Patrick Paul in 1974 and international organizations like Bible Medical and Missionary Fellowship, now Interserve, Eco Holland, Christophilis Blind Mission, Oxfam, Tear Fund, World Vision and Church World Service. The present staff is comprised of 40 individuals, among 3 lady medical officers are serving. Since the hospital inception, there has been a nurse aid training program at Kunri Christian Hospital. In 1991, the Midwifery School of Nursing was also established by the efforts of the management of that time. The vaccination department of Kunri Christian Hospital is providing vaccines to children with an objective to prevent fatal diseases. In collaboration with the Government of Pakistan, expanded program for immunization. Kunri Christian Hospital has been serving humanity since 1962 with an objective to alleviate health-related problems and assist Government of Pakistan in creating a better, healthier environment for people of Pakistan in general and Sindh in particular. The hospital provided hope for poor patients of the area. Many blind people got their vision back after successful eye surgeries. Many children were born through normal deliveries and cesarean sections. Many dying patients survived after proper treatment and management by the excellent service of doctors and the hard work of paramedical staff. The community health program of the hospital did an excellent service by giving vaccines to children and providing awareness to the
places I've worked, you're right, you need the women to do the work and to do the education, but if you don't educate the men at least enough to make them comfortable with these new ideas you're bringing in, you don't get any buy-in and they don't get permission from the husband.
The other question I had was, were they paid or were they just volunteers?
Educated the men this year, and we had talked to the men originally and gotten their buy-in, but we did educate them this year. They came for a 3-day training, and that helped immensely in terms of getting their buy-in. We did not have the funding to do it initially, and that's why we had to put it off for a year until we could actually get the funding to do it. And yes, the community health workers are paid a very small stipend. It isn't much, but one of the issues that we're having now, of course, is with sustainability and figuring out how to sustain the program because they are getting paid a small stipend, even though it's small.
How many hours per week?
It depends upon the size of their village, but they estimate they're spending probably about 16 hours a week. Yeah, yeah.
So that wouldn't be considered voluntary work.
Right, yeah.
So let's let our speakers up front finish quickly here, give you 2 minutes, and then we'll take questions for all 3 speakers.
This is a team of Kunri Christian Hospital. In the center, Right Reverend 4th Bishop of Diocese of Hyderabad, Kaleem John. And on the other side, whole team of KCH, Kunri Christian Hospital. We are comprises on 40 individuals, including 3 medical doctors and 1 male medical doctor. Hope for poor patient. If Kunri Christian Hospital is not able to receive or admit the patient, then the women, she have to travel 3 hours to go for a good hospital. Sometimes they die in a way, and sometimes they reach. This is a map of Umarkot district. According population is approximately 7 lakh, about literacy rate I told you. And this is a situation of Kunri Christian Hospital in November 2007, when me as a medical director and my husband Naveed as an administrator joined the Kunri Christian Hospital. Kunri Christian Hospital was the verge of collapse, and the bishop of that time, Rafiq Masih, he requested us that we go and see the building of Kunri Christian Hospital, and if we'll not join the hospital, then the administration will lock the hospital. By the grace of God, we achieved a lot in these 8 years. This is the situation in 2007. You see boat, when flood came in Pakistan in 2011, hospital was full of water. And after that, this is a new situation of hospital. You saw a person with white national dress. He is a member of National Assembly. We people arrange a Christmas get-together, and then the guy gives us 10 lakhs Pakistani rupees for the renovation of hospital. This is accomplishment of KCH in 9 years. You saw that we are doing some community-based health program, nursing aid program. These are the success stories. Still, mothers are dying with eclampsia, with anemia, pregnancy-induced hypertension, placenta previa type 3 and 4, and many other diseases which you never found in developed country. These are our future plan, that we want to revive the hospital, we want to reopen the eye department, we want to upgrade the laboratory. This is a graphical view. You saw in 2007, the general OPD was 307 only, and in 2015, it is 1826. Thank you. We need your support, guidance, and prayers. One person from US, I always remember and acknowledge him, that is Edward Morrow, Medical Director of Christian Medical Mission, an arm organization of Samaritan Purse. In 2009, he gave us big container, including all medical equipments, like general anesthesia machine, incubator, ultrasound machine, and all other basic necessaries which we are using in hospital. Thank you very much.
Okay, thank you so much to each of our inspiring speakers, and we do have a few moments, thankfully, for question and answer. So I'll step down here and get microphones.
Okay, my name is Linda Funke. I do work in Tanzania with the Evangelical Lutheran Church of Tanzania, and I have a question just for all of the panelists, but then also anyone out there. I'm wondering if anyone's had experience with community health evangelism programs, the CHAP programs. It's something we're thinking. It sounds very similar to the community health workers, but also incorporates some of the spiritual aspects. And I'm just wondering if anyone's had experience with that and how it's worked as we're thinking about incorporating into the Lutheran ministries.
World Vision has a model that is called Channels of Hope. And the model, basically what it does is to integrate into the community approaches religious leaders. It started with HIV, in the area of HIV, because of the, all of the misunderstanding that there are in relationship with HIVs. But it has gone beyond even to family planning. Right now it has a model to integrate messages from the Bible and or the Quran into the health delivery messages, so as to have some sort of a reflection between the religious leaders about what the Bible says and what the Quran says in relation with some of the areas that we want to address that are health related. And then they go, once they have that training, which is, I believe, 1 week training, then they incorporate these messages into their dialogue with their respective communities.
Another question, or anybody else with
Yeah, Frank Demick with the Presbyterian Church. We are focusing on CHAP programs, community health evangelism programs, in a number of countries, and have many of our co-workers in the field who've been trained in CHAP through medical ambassadors or life wins. And I encourage a lot of folks to go on the website and learn about community health evangelism. It's an effort of our church to sort of break down some of the silos of evangelism, health, and education, and try and integrate all of these at community level. And I think we've, anecdotally, we've shown some real success in places like Western Ethiopia, in Congo, in Malawi, in Zambia, and now in Thailand and Guatemala and Haiti as well, where we're working with communities in Bible study and health and education to try and integrate a lot of the focus in health.
I would echo that. I've also had quite a bit of experience with CHE, so I'd be happy to talk to you another time as well. So, okay, other questions for speakers?
The curriculum was mentioned. Is there a one-stop shop where one could find these curriculums that were used?
I'd be happy to share the curriculum that that we used, and I see that Connie left, but the other curriculum that's used is the JOMCAD curriculum, and that would be another one to look at as well. But yeah, I'd be happy to share ours too.
I noticed that you were transferring the skills to mental health. Why did you decide to go that way? And what was the impact of this? I mean, were you able to follow them to address the consequences?
The reason that we did it was because we had been told that hypertension was an issue within the community. And we taught them at the beginning of the 15 days and measured their competency during it. And then during the refresher training, we measured their competency as well. And interestingly, we do believe that the one of the few data points that's accurate in our data collection is the hypertension. When I followed up with them and asked them how they asked the question about hypertension in their community, they did report that they asked, when they asked about hypertension, that it was measured by a physician. And in 3 of the communities, they report that 65% of the adults have hypertension. So we do believe that it is a significant issue, and we're following up to see, if they are going back and measuring it with the people who are reporting high blood pressure, and then making sure that they're going back and taking the medication and going to see people in the clinic. So it is something that we're following up on, and then we're trying to figure out if there's something more that we can do with them to address the issue within the community.
I had a question as well. My name is Stephen Blas. I'm a recent graduate of Johns Hopkins, and I had a question actually about the Maasai Rural Health Project, and the question about referral. I was curious, the distance that they're having to travel. You mentioned the facilities, and then that they're semi-nomadic people. So I wonder, first, are the referrals being effective from a community level? And then if you've identified barriers to referral, what transportation barriers possibly, or other barriers, what types of interventions have you developed to help alleviate those barriers to facility-based care?
Transportation is the biggest barrier, and with transportation, it's finding transportation to get there, and then the money for the transportation. So, for example, during the rainy season, it's impossible to get transportation to get anywhere because the ground is impassable, and so it's really challenging just to get anywhere. And then getting money together, because money is something that the Maasai don't typically have because it isn't important to them. So they have a lot of cattle, they have a lot of goats, but they don't have a lot of money. So to get anywhere, they have to raise money within the village and sell a goat or do something to get the money together to actually hire the transportation to get somewhere, which they will do if the person needs to get somewhere. They're very, very community oriented, and they're very supportive of getting somebody to get somewhere. And so they will do it if somebody needs the transportation and needs to get somewhere and needs the referral. That's not a hesitation, but it's actually finding a way to get the transportation, getting it out there, and then can it get there and get back.
What effect have you seen on the training as far as the community health workers themselves, and maybe their position in the community or the view of women in the community based on their training? And does that help with the sustainability then of the continued community health worker impact in that community as well?
The community health workers, they're thrilled by their training. They absolutely love it, and they would love to go on for more. They'd love to be nurses and would be thrilled to be able to be supported to have that kind of education. Within the community, it's raised their status within the community. And you know, the community really has a lot of respect for them, and I think that will only continue to grow as they continue to demonstrate their ability to care for people and really to refer people, and that people are gaining from what they're doing, particularly around health education, which I think, you know, that takes time to demonstrate. It's one thing to take care of a cut or a wound and see something happen, but it's really for us as the health education and the demonstration that the whole community is benefiting from what's going on.
Well, thank you very much for your attendance and participation and fantastic questions. Thank you to each of our speakers, and we pray God continued blessing on your work. And so it is now time for lunch. So hopefully, please take some time, come up if you have more questions for our speakers. But again, thank you for your participation.